Well, thank you so much. I'm expecting the presentation today to take about 40 minutes, and we'll split it between Jannah and myself. I'll provide a background around health promotion, research and evaluation, and Jannah will kind of finish off with a bit of a case study about how that's looked for one program that we initially developed in Hunter, New England, but is now a program that is being supported by other LHDs. I just wanted to start by acknowledging the traditional custodians of the land that we're meeting on today and recognise their continuing connection to land, waters and culture, and of course pay my respects to elders past, present and emerging, and welcome those Aboriginal and Torres Strait Islanders who might be joining this workshop today. There's a couple of useful resources that it might be helpful for those of your team who are engaged in research and evaluation. I've put a couple there. Many of these are really relevant because they were developed by the Ministry of Health or the Centre for Population Health. So there's the Population Health Guidance Series, which has a rich source of evidence resources. Of course, there are also some really good workshops and webinars that have been presented or facilitated by the National Centre for Implementation Science, including those undertaken by Adrian, and some other planning and evaluation framework tools from WHO or other Australian jurisdictions like Victoria. Here we go. Okay, so today, look, I'll essentially provide you an overview with a background about health promotion evaluation and why it's important. I'll then go on to talk about when and why we might undertake health promotion evaluation, how it differs from research and how it can be used for the improvement of health promotion services. It's a pretty superficial kind of presentation today. I'm not talking about, in any detail about how to conduct a rigorous evaluation, anything specific about research design, measurement or sampling. Of course, I'm happy to discuss those during questions, but I thought what would be most helpful today is just start at the top and provide broad background into health promotion evaluation as it is in our field. So by way of background, health promotion and its value was really questioned, and health promotion research was really considered a pseudoscience. And it wasn't really until the early 1990s that health promotion, like medicine more broadly, adopt an evidence-based paradigm, meaning that health promotion as a profession was clearly articulating that it valued evidence as a pathway for improving the health of populations. And WHO at that time suggested that there should be at least 10% of health promotion budgets or health promotion services allocated to program evaluation. Over time, the role of evidence and research in health promotion practice, I guess, has continued to be strengthened. In 2001, WHO then recognised that with evaluation, health promotion efforts can be more equitable, empowering, more participatory, more accountable, and ultimately more sustainable. And today, health promotion practice is really being seen as a learning health service or a learning health system where the practice of health promotion and research and evaluation are seen not as separate entities or separate activities, but one in the same. Research should inform practice, practice should inform research that's being undertaken. It should all occur as a kind of a continuous ongoing loop that strengthens the impact of the services that we provided as part of our local health district or indeed other national or international agencies. So evaluation is seen as a core component within New South Wales Public Health Trainee Competency Framework. And if you're a member of the Australian Health Promotion Association, you'll know that it is a core entry-level competency for health promotion practitioners. So research and evaluation skills should be something that all health promotion practitioners can undertake to some degree because it is seen as really core to what we do. So what can research be used for? in health promotion. It really can be used for a variety of things, all the way from problem identification. So identifying, what are the key issues or health challenges in your community, how frequent are they, and what are the factors that determine them. That information can then be used to develop a program theory or a logic, essentially to help you better understand the health issue and inform the development of solutions to address it. And this type of problem identification research uses largely epidemiological type methods. It asks questions like, how common is alcohol dependence? In which population groups is it most prevalent? Does it get worse over time? What increases the risk of dependency? And how likely would those with alcohol dependency be to use a solution that you might be thinking of, such as the telephone support service? So the application of research and evidence in problem identification, I'm not really going to talk about today. I'll talk more about the use of research in solution generation, and that is really the role of program evaluation. And as part of program evaluations, we're really looking to develop solutions to address the key issues that are being experienced by our community. And so to do this, we assess or test the potential impacts of interventions or other policies or initiatives to address these problems. And that program evaluation and the findings of that program evaluation can then also better help us understand the drivers of that problem. So that informs refinements that we might make to our underlying program logic or theory, or essentially our understanding of that problem and how it can be improved. And program evaluation usually uses trial, but also qualitative methods, but usually has a kind of a comparison group, because program evaluation is about understanding the value of a particular service or initiative. And so we need a counterfactual for program evaluation. And that means we need some form of kind of comparison group with which we can compare, a particular interventional program versus, nothing or an alternate program or intervention. And so just staying on the example of alcohol dependency and how you might reduce that in your community, a program evaluation might look at assessing the effect of a telephone support service to reduce alcohol dependency, and ask if it's more effective among particular population groups. For example, those that might experience greater alcohol dependency, is it cost effective, and is it more effective providing a different solution or an alternative, like simply providing educational or print materials to address that problem. Sorry, there's just a big delay every time I go to change my screen. Here we go. Okay, so why should we evaluate? So I've mentioned that evidence is a core value of the profession, and the primary reason that we evaluate is because as a discipline, as a profession, we believe in evidence-based practice. We're subscribers to evidence-based medicine and evidence-based medicine methods. And that means that we want to make sure that what we do is effective and is beneficial for the communities or the populations that we're seeking to improve the health of. And despite, health promotion is a field of very committed professionals that are filled with the best intentions. However, many of the things that were born of good intentions don't actually have the intended value that they were thought to have prior to their implementation. And there's plenty of examples of this at kind of a local level, but also really high profile, expensive initiatives that have been undertaken by, the Commonwealth or the state government. And so a good example of that is the Active After School program, which occurred about a decade or so ago, a very expensive Commonwealth funded program that existed for about 10 years to get children more physically active. There's been some evaluations of that program to suggest that, that it had no beneficial impact on that behaviour at a population level. And similarly, the largest investment in prevention by the New South Wales state government has been the Active Kids Voucher program, $200 million, like incredible amounts of money. Again, this was an initiative that had a dual focus, one of which was to, again, try and support children to be kind of physically active because of the health and wellbeing benefits of physical activity. There have been, again, some evaluations of this initiative, which again suggest that it hasn't lived up to its expectations. So, very marginal benefit, particularly given the considerable sums of money that were invested in that initiative. So we want to make sure that what we do works. We also want to make sure that it does no harm. And this is something which is often easy to overlook as health promotion practitioners, because we often think that the sorts of initiatives that we engage in are likely to be beneficial and are very unlikely to do harm. But it's important that you appraise the potential for harm when you're developing your health promotion services, and include some measures to check that no unintended harm is occurring. And there's a couple of really high-profile examples where harm was done through really large investments in public health. In the US, two really high-profile examples are virginity pledges. So these were school-based initiatives funded in many of the southern states of America, where students were encouraged to make pledges of kind of sexual abstinence in an effort to try and reduce unwanted teenage pregnancies and STI infections. Evaluations of that program suggest that it didn't achieve either of those objectives, and in fact it made it worse. Schools that took on these types of programs had worse, higher prevalence of STIs and unwanted teen pregnancies as a result of these programs. Similarly, there's a program in the US called Scared Straight. This was an initiative where adolescents who were in the juvenile justice system were introduced to prisons in the US and exposed, I guess, to hardened criminals in the hope that that would kind of scare them away from committing future crimes. And evaluation of those programs said that it increased the likelihood of reincarceration or incarceration of juveniles that attended that program. So it had an effect counter to its hypothesised effect. So some examples that are kind of more local that you might be a little bit more familiar with that might be relevant to your health promotion practice. Initiatives like No Hat, No Play are a great skin prevention initiative. They've taken root within primary schools across New South Wales and indeed across Australia. However, there is some suggestion that these types of rules within schools may actually reduce physical activity if they're not managed well. So while it may have a beneficial impact on one risk factor for chronic disease, it may have an adverse effect on another. And within childcare services, pressure feeding practices, or within any setting, but pressure feeding practices to even if they're directed at fruit and vegetable intake, for example, may, there's really good evidence now that actually has an adverse effect. So if you pressure children to eat, they are less likely to do it and can actually reduce their intake of fruits and vegetables. So doing no harm and being aware of the potential for programs to do no harm is a really important consideration when we're designing our evaluation initiatives. It's important to evaluate for accountability to justify the incredibly scarce health resources that we have, and importantly to learn from others, to share our own learnings and to improve health promotion services locally, but also for the field. So unless we evaluate and share the findings of our evaluation, then our learnings won't help other health promotion practices or programs that are encountering the same sorts of problems. We also need to evaluate because much of what we currently do doesn't work. And this is not unique to health promotion. In clinical medicine, they estimate that only about 60% of clinical services are consistent with kind of contemporary evidence-based guidelines or contemporary evidence standards. 30% is unlikely to have any value, so that's what we call or low value, and 10% is likely to be harmful. For public health or within our field, there's been a number of studies that have tried to get at the same thing, and the results are very similar. So in the US, for example, about 60% of programs that were enacted by public health practitioners and their agencies were deemed evidence-based. And so that means, 40% or 42% are not. And that is a real issue. I don't expect this may have changed much, nor do I expect it to be much different in Australia than it is in the US. And probably finally, we need to evaluate, because investment in health promotion services are often under threat. And so it's really important that we demonstrate the value that we add to the health system. And some of you may have been around for some of these big initiatives or big events in Australian health promotion, but I'll just kind of remind you of a couple. In 2012, when the Newman government took power in Queensland, they essentially cut all prevention services in the state, and so there was a lost health promotion workforce within Queensland that really is only now just kind of beginning to get back on its feet. And that led to New South Wales was a big beneficiary of that cut, because many of the dietitians and the health promotion practitioners from that state moved interstate and took up roles within New South Wales Health Services. But that was a staggering and incredibly adverse impact on the prevention health system, and indeed the health of Queenslanders as a result of that. Cut. The largest funding increase from the Commonwealth in prevention came during the Rudd government, when there was the National Prevention Partnership on Preventive Health. So this sent hundreds of millions of dollars to the states to undertake prevention work. How the states used that prevention funding differed across jurisdictions. In New South Wales, we had a very evidence-based, kind of non-experimental, but very rational use of that funding to support the implementation of evidence-based programs using evidence-based implementation strategies that were informed by the Good for Kids, Good for Life kind of demonstration project that had happened, a few years later. When the Liberal government returned to power, that funding was cut, and in New South Wales was the only state in which the state government agreed to pick up most of the shortfall in funding that resulted in the Commonwealth's funding being removed. Most other states, returned to what they were before the National Preventive Health Partnership. But it was I'm happy to talk more about this, because I feel quite passionately about the use of data and how it was the reason that New South Wales Health kind of survived this federal funding cut. And all the work that's happening in HCI at the moment, for those of you that are involved in those initiatives, is a result of the New South Wales government continuing the funding that originated from this service. But data was critical in making the case to the state government of the value of prevention. I guess it appears now that certainly in Victoria, it looks like there are cuts to health promotion coming, and in New South Wales, there are some concerns that cuts to health promotion may also, be in the future. I just wanted to, this is a little bit as an aside, but there is a really good evidence brief that was published by the Australian Prevention Partnership that talks to the value of prevention. And this was put together by the Partnership Centre at the request of the directors of many prevention agencies across Australia, being concerned about the need to demonstrate the value of health promotion and what we do in order to ensure the longevity of health promotion as a profession in Australia and its kind of contribution to the health system. It's a really, really, particularly for the kind of senior managers, this is a really valuable document to refer to if you're, talking up within the LHD or talking to the ministry or other other funders of your work. Okay, before I provide a bit more detail about what health promotion evaluation looks like, it's important to kind of characterise what health promotion practice looks like. And broadly speaking, I'm making some generalisations here, but broadly speaking, how health promotion services have impact is they support other agencies to create health promoting environments or to deliver health promoting services. So rarely is a health promotion practitioner directly delivering counselling, advice, support to a member of community. Health promotion typically adapts what we call a capacity building approach, where we build the capacity of other agencies who will then go on to deliver in an ongoing way, we hope, preventive health services or health promoting environments to the population that are exposed to those settings or organisation. And so this approach enables population level reach, and it is intended to support sustainable change. So when we step out and stop providing support to those agencies, we hope that we've built sufficient capacity that they kind of continue on, and then we move on to the next challenge or the next setting. And so the mechanism for impact is we take, we take evidence-based interventions, we work with agencies to integrate those evidence-based interventions in that setting, and we achieve population health impact, and we kind of rinse and repeat at different risk factors and in different settings. Okay, so when and what to evaluate? I just wanted to kind of reiterate that the points made in the earlier slides that, in contemporary health promotion practice, data is not distinct from practice, and health promotion should use data routinely to improve its services. And data can be formal data collection, where you go to ethics and you develop a survey and you collect information through a questionnaire. But it doesn't have to be that. It can be simply reflective practice. So your experience being out in the field, talking to partners, observing things when you're in a school or an outpatient clinic, but having a system or a process in place by which you bring that information back and you reflect on it and you think, well, from what we're observing, what we're hearing, what we understand, how can we improve what we're doing? What should we change? Because nothing we do is ever purpose, and this kind of data and reflection and improvement should really be routine for everything that we kind of do. Evaluation is a more formal assessment of the merits of a health promotion activity. It's really getting to, is there value in this health promotion activity that we're undertaking, or is there sufficient value to warrant the investment that we're providing it? And so what an evaluation might looks like will depend on how certain you are that the activity is beneficial and that it does no harm. And so you might not need, for example, to undertake an evaluation to re-establish the effectiveness of a proven intervention. So if you know something works, if it's in a systematic review, if it's in a best practice guideline, you're kind of confident that, yeah, well, this will clearly work in our context as well, then you don't need to evaluate that program because you know it works. It'll also depend on its stage of development, and I'll talk a little bit more about this in a moment. And so we have a research process a health promotion process where we kind of take new innovations or ideas, and ultimately we're looking to achieve population level impacts. And so we work through a systematic process of checking that they're effective and do no harm, and then we move them through stages all the way to when there's a lot of money going into their large scale deployment or implementation across a setting. And where you are in that process will depend on, what you evaluate and how intensive that evaluation looks like. And of course, your evaluation will depend on resources that you have available, the pragmatics or other kind of external influences. So in terms of what to evaluate, when we evaluate, because we're typically interested in value or benefit of a particular health promotion service or activity, essentially what we mean by when we say those words is, well, is it having, what sort of impact is it having? And there's a framework called REAIM, and it kind of recommends, I haven't included the adoption dimension here, but it recommends that we, that we achieve impact when we have an effective program that's reaching lots of people, that's being implemented well, and then it's maintained over time. So impact is kind of like the product of those factors: effectiveness times reach, implementation, and maintenance. And so when we evaluate effectiveness, we're really asking, well, does this program work? And usually that's a measure of behavioural disease, what someone's eating, how much exercise they're doing. Reach is really asking questions of, to whom does this intervention, is being exposed to this intervention, and are there likely to be benefits? And so we are particularly interested in reach when we're interested in population level impact. We want large numbers of people to be exposed to the intervention, but also reach is a really important equity question. So are people who really need this, disadvantaged communities, for example, are they being exposed to it? Do they have access to it? And importantly, are they benefiting from it? We measure implementation, which is typically some assessment of how well a program is being adopted and delivered by the setting or the organisation which you're hoping it will be routinely delivered. And we're really looking to assess, is this program being implemented to a level sufficient that it's going to retain its effectiveness? So how adequately is it being implemented? And maintenance is really asking the question, does this program continue, will this program continue to be implemented when your support is kind of removed? So it's a measure of, for how long the intervention is going to be delivered and accrue those population health benefits. Also critical in evaluation are measures of cost, particularly to providers or the health system, who are actually funding the activity. Acceptability to providers, and by providers, I often mean the setting or the health promotion unit itself, like the LHD. But also acceptability, of course, to patients or the population of people you're looking to expose the intervention to, and feasibility, like can this program be delivered, or can this intervention, is this intervention likely to be able to be delivered within the resource infrastructure, and, political and other environmental factors. And so I mentioned that the emphasis on what we measure will change by the stage of development. So when you are at ideation, and by that I mean when you're thinking about what you might do, a new service, then you're really looking to like stress test an idea, using very low cost measures. And so these things might be, feasibility or acceptability. So you're kind of kicking around an idea with your key partners, or you might speak to, the setting or the your stakeholders about an idea. You might speak to your management about the resources that would be available to support this program if it was to progress. And so in ideation, you're really focused on feasibility and acceptability. And often this can be through reflective practice and what I'm kind of calling scrappy experiments. And by scrappy experiments, I mean, it could be that you, in the context of delivering a health promotion service, that you just kind of informally, cheaply testing ideas based on, their acceptability. And what you're trying to do here is screen out all the bad ideas. Like you're trying to, and most ideas that you have will be, not good ideas. I mean, certainly in our experience in Hunter New England, we have plenty more ideas than we have good ideas. And, a process that cheaply refines those to get to something that you think might be worth testing is really important. And almost the more ideas that you have, the more likely you are to find and can eliminate, the more likely that the idea that moves through that ideation process is likely to be beneficial and be, beneficial and have real kind of population level impact. But once you've gone through that type of process, then you're then really wanting to test the effectiveness of an idea that you're confident is feasible and has acceptability. And so here you're looking at, does the program improve health behaviour and for who? So this may involve like a more formal kind of trial that you need kind of ethics approval for. Once you've established something as effective and it's kind of feasible, acceptable, then you move into a service delivery and kind of mode, and you're looking to kind of develop systems and strategies to support the implementation of that effective program. And here you're looking at, an evaluation will really focus, less on effectiveness because you've already established that. You're really just wanting to look at, well, what are the strategies that I have in place that can get the school or childcare service, the sporting club or the outpatient clinic to implement this intervention. And when they do, who does it reach and how much is it going to cost? And then finally, in the evaluation, there is also this maintenance phase. This is often characterised by service withdrawal. Health promotion services typically don't stay in settings forever. At some point, they're looking to withdraw based on that capacity building philosophy I mentioned before. And I'm happy to go into what maintenance and what the evaluation of a maintenance initiative might look like, but I've deliberately decided not to cover that today because I thought we're just covering too much material. And so health promotion units will probably have a patchwork about evaluation activities. There'll be some where, there's some health promotion services where there's no formal evaluation because you've got highly effective, well-implemented programs. You might be looking informally for opportunities for improvement, but, there's no need or no value to be gained from undertaking a formal evaluation. There could be others where you're piloting or formal testing new interventions or new innovations. As I mentioned before, you're looking to do that because you're wanting to establish that they're effective and beneficial before you then invest substantially in their broad implementation. I would say less than 50% of innovations within our district survive that piloting and formal testing. There are many programs that we find are ineffective or not sufficiently effective that we kind of retire, or at least we don't invest in further implementation for because we don't think it's of value. And then there may be other services where you're assessing the extent to which a health promotion officer support is effective in improving the implementation of a proven intervention in that setting. And finally, there may be some monitoring activities where you're just kind of checking that existing evidence-based programs are continuing to be delivered, when a health promotion officer or health promotion service ceases to provide support. Okay, I'll just move. I've talked about this research stages. I just wanted to I'll include these slides, but there are a number of evidence resources that's really helpful for informing the design of evaluations. The image on the left here just looks at different research designs for different types of research questions that you might use depending on the stage that you're at. This is a resource, an image I pulled from a WHO resource, which I realised I haven't referenced here, so I can provide that if you like. And there's other resources to databases that are freely available of systematic reviews. Cochrane is one, but which is freely available. Another one is called Health Evidence, which is really, really good and probably, I think, most easily navigated. And it's a Canadian Institute of Health Research funded database that focuses on public health issues and health promotion issues and collates the best available evidence for interventions in that field. So to help navigate, what an evaluation might look like depending on, the stage of your health promotion service, we are about to publish this kind of schematic with the Australian Prevention Partnership Centre. I'll just it really describes what the stage of the research translation stage is, or the stage of development and implementation of a health promotion program is, and what a research evaluation action or a prevention agency, in this case a local health district health promotion action, might be given that stage. And so for an identified health problem, the first question is, if I'm wanting to have an impact on my community, then I need to make sure my health promotion service is effective. And it's to assess whether your health promotion service is effective. The best place to go is to is to look at the scientific literature, in particular systematic reviews and best practice guidelines, to appraise the likely effectiveness of the program or the initiative or the policy or the practice that you're looking to implement as part of your service. So all health promotion services need to be effective if they're going to have an impact, and I understand that's a very obvious thing to say. However, removal of ineffective programs is probably the most impactful action a health service can take in improving the impact of its service as a total. And that's because it allows reinvestment of health service or health system funds away from ineffective programs to effective or more effective programs. And so an audit of health promotion services to ensure that they're effective is a really kind of prudent activity for, you know, any LHD and in fact any prevention agency to do. So once you have an effective intervention, and you can appraise that using systematic reviews, you then need to ensure, even for proven interventions, that they are suitable for the context that you're looking to implement them, particularly at the scale you're looking to implement it at. So you really need effective interventions that are suitable, you know, acceptable, feasible, scalable, within the context and the resources of your LHD. So they're the two actions that need to be, or decisions that really need to be made by LHDs. And as I mentioned, to assess the effectiveness of interventions, look to the scientific literature, systematic reviews. If you don't have any effective interventions, or you don't think that interventions that you have are suitable for implementation in your context, so you don't think they might be effective but they're not kind of suitable, then you should, you know, undertake you know, an evaluation. Like you should develop and evaluate the effectiveness of the program that you're implementing or that you're wanting to implement. I mentioned this before, so if you have no suitable effective interventions, then consider developing and testing one. Just to briefly go over, you know, the process of that involves, you know, first focusing on screening ideas based on measures of feasibility or scalability, undertaking those scrappy experiments, formally piloting promising programs, and then formally test programs that have kind of survived a pilot. And when you're formally testing, you're moving from considerations like feasibility, acceptability to effectiveness. So the outcome of this process is kind of early abandonment of interventions that aren't going to be effective, or improving those that you think are promising, even if they might be ineffective, that they're promising, improving to the point where you can get them to be effective, or that you can get them to a point where you think that they're suitable, amenable, kind of contextually relevant for where they're to be implemented. The intervention scalability assessment published by Andrew Millack provides some ideas about the sorts of things that you can measure and consider when you're assessing the suitability of an intervention. Just going to check the time. I'll move through quickly, just JJ, so you've got a chance to provide the case study. But once we have even if when we have effective interventions, they need to be effectively implemented again if they're to have a population level impact. Similar to the process of developing an effective intervention, effective implementation strategies may exist for the program or policy that you're looking to deliver as part of your LHD. You need to kind of appraise whether there is an effective implementation strategy for your intervention by looking at, again, systematic reviews or guidelines. Again, you don't need to re-evaluate or retest proven implementation strategies, but you may need to appraise their suitability based on context. And so by implementation strategies, I mean things like training or health promotion officer support or facilitation, or incentives or audit feedback. Again, if there's no suitable way to implement an intervention exists in the literature, then you can consider testing one, and particularly testing one that you might use as part of your practice. So it could be that you've got an effective intervention and you're just going to start implementing it within your LHD, but in the context of implementing it, then you evaluate how well that's been implemented. Again, you go through the same process for developing effective implementation strategies. You kind of screen ideas, you can pilot, or you kind of just formally test or routinely test the implementation strategies you employ as an LHD. And here you're focusing on measures of implementation and reach, like what proportion of clinicians are referred to get healthy. What proportion of clinicians refer their patients to get healthy if you were working in an outpatient clinic trying to encourage clinicians to undertake that practice. Again, here the outcome could be the abandonment, or you could use the findings of these evaluations if you think it's appropriate and sensible to do so for ongoing improvement. Okay, JJ, I'll hand over to you. Did you want to share your own slides, or do you want me just to?
Yeah, I might share my own if that's all right.
Sure.
Thanks, Luke. All righty. Thanks so much. So I'd like to begin by also acknowledging the traditional owners of the land that we're meeting on this morning, and pay my respects to elders past, present and future. So we just thought that it might be helpful following sort of Luke's presentation to chat through a bit of an example of how we've sort of applied this approach within one of our projects here in Hunter, New England. So yeah, just a little bit of a case study around the development and evaluation of a school nutrition intervention. And so I'd just like to also acknowledge Dr. Rachel Sutherland, who has been leading all stages of this program. So I thought I'd sort of take you on a journey of how we evaluated both the effectiveness and cost effectiveness of a scalable lunchbox intervention called Swap It. So using sort of a range of different evaluation approaches to address the concern that we have regarding overconsumption of discretionary foods by children in the primary school setting. And you can sort of see on the slide, I'll chat through, I guess, the process that we've gone through and where we are now. So from program development through to piloting the program, conducting an effectiveness study, and then moving to implementation and scale up. And so just a super brief background in relation to school food systems in Australia and lunchboxes specifically. So obviously we all know that more than 25% of children in New South Wales are overweight or obese, and that schools, primary schools in particular, have been identified as a key setting for health promotion and behaviour change. We know that every day in Australia, almost 90% of primary school children are consuming between a third and a half of their daily energy intake within the school lunchbox, and that within these school lunchboxes, there's more than 3 serves of discretionary foods, which accounts for about 40% of the energy within these lunchboxes. So lots of scope for improvement. So what is the Swap It Healthy Lunchbox program? So it's a population-based healthy lunchbox program that leverages the authority of the school and also utilises existing school communication networks and systems. And so super briefly, just embeds text messages that are sent directly to parents' mobile phones to support parents and carers to swap what's packed in the lunchbox from sometimes or discretionary foods to everyday foods. Really from the outset, it's been designed to be scalable at a population level. So in relation to, I guess, the steps or the processes that we took to develop and evaluate Swap It, we started at the program development phase, and the key sort of research questions or things we were interested in at this point were what stops parents packing a healthy lunchbox, and would it be acceptable to develop a program to support parents to pack a healthy lunchbox. So firstly, we conducted a systematic review to look at sort of what evidence or previous trials were out there that had sought to improve the contents of children's lunchboxes. And so what we found was that there was actually a really limited number of trials, and those that had been conducted, these were largely ineffective or like super costly, so not being scalable or sustainable. So I guess we identified quite a gap. And then following this, we undertook a bit of formative research where we conducted some focus groups with parents and surveys with both parents and school principals, and we were really trying to identify what the key barriers were to packing a healthy lunchbox. So these ended up being knowledge, time and convenience, cost, food safety and child preference. And we, I guess, use this information to determine what barriers we would target as part of the development of our own lunchbox intervention. So we then use theoretical frameworks and some behaviour change techniques to try to address these barriers and co-designed the Swap It program. And so I guess the premise of the program is really just about making simple, healthy lunchbox swaps. And it was developed as a population-based behaviour change program, really targeting those parents and carers of primary school age children. So it kind of has three main components of the program. So there's some curriculum and classroom resources to support teachers. We work with schools to create nutrition guidelines. So really looking at that, creating a supportive culture or environment around nutrition. The primary component of the program is the messaging that's sent directly to parents' mobile phones via a school communication app or using usual school communication channels, providing parents with those tips to packing a healthy lunchbox and making the swaps, and also some other program resources. So following the, I guess, program development phase, we then moved on to a pilot phase of the program, and really our main sort of questions we were wanting to answering in this phase were, is the program acceptable to school staff? Is it feasible for schools to run, and does it have the potential to make a difference to children's lunchboxes? So we undertook a small pilot study. Our primary aims were assessing the feasibility, acceptability and cost of Swap It. And so what we found throughout this stage of the program's development was that I guess the findings were very positive and promising. So 89% of parents downloaded the school communication app. 71% recalled receiving our lunchbox messages via the app. 84% said the content was really helpful, and 95% reported the weekly messages being acceptable frequency. School principals, all of the principals involved in our pilot recommended Swap It to other schools and wanted to continue to implement the Swap It program as well. And when we looked at the cost of the program, we found that the cost was approximately $6 per student. So I guess based on the exciting and promising findings of our pilot study, we then decided to progress to an effectiveness study. And so really the questions we were interested in answering in this phase were, does the program improve student nutrition? And do parents, teachers and principals like the program, and confirming that it's appropriate and feasible, so building on the findings of the pilot. So we embarked on an effectiveness trial, the primary purpose being assessing the effectiveness of Swap It in decreasing energy content from discretionary foods and drinks packed in children's lunchboxes. So this was a cluster randomised control trial, and it involved 32 schools, half of which were allocated to the intervention. And as part of this, the evaluation of this trial, we went in and audited school lunchboxes at baseline and then following the delivery of the intervention. So we analysed more than 2,300 lunchboxes. And what we found was that there was a significant reduction in terms of kilojoules that were coming from discretionary foods in children's lunchboxes. So that was the equivalent to around a reduction of 600 kilojoules from these foods per week in children's lunchboxes, and also a total decrease in kilojoules per day. So a decrease of 88 kilojoules per day in school lunchboxes. So overall, really positive, significant and meaningful findings. So I guess based on those findings, we then, the project has now moved into an implementation and scale-up phase, whereby our focus is really on answering the question around how do we get schools to implement and adopt the program at scale. So as part of this work, we're undertaking a randomised trial, and special thanks to Jenny and Pip and Matt and Hayley that we've had the privilege of working together with on this piece of research over the past probably 2 years or so now. So really here we're aiming to assess the effectiveness of a multi-component scale-up intervention on school level adoption of the SWAP It program. So this has involved another randomised control trial with 340 schools that have been located across 11 local health districts. So it's been a wonderful opportunity to work collaboratively with many LHDs on this piece, trying to answer this question together. And the strategies that we've been, I guess, evaluating in this phase have been looking at the impact of integrating via a web platform and an automation piece, trying to raise awareness by printed information, providing printed information packs to schools, using local contacts and local facilitation by LHD Health Promotion staff, looking at the impact of an endorsement letter from New South Wales Health, and looking to engage PNCs to gain that parental support for the program. And our key sort of measures, or what we've been focusing on in this phase, have really been that school adoption of the SWAP It program, looking at the acceptability of these implementation or scale-up strategies, and also looking at what the school level barriers and enablers are to adoption of the program. And I guess excitingly, we've had 40% of schools across that have been involved in this trial adopt the SWAP It program across 2 school terms, which, yeah, has been a really exciting finding. So yeah, hopefully that, I guess, gives you a little bit of a insight into how we've progressed throughout the different sort of phases and how we've evaluated and decided whether to progress or not through each stage.
Thanks, Jannah. I think you probably will. I will wrap it up. So if you could just click through that last slide. I mean, I think that's very much a Rolls-Royce version of kind of best practice application of evaluation methods to develop and scale up a program. I guess I just wanted to make the comment was that, you know, certainly not all evaluation activities have to follow that level of rigour, and indeed that level of rigour was only made possible because of substantial kind of external investment from the University of Newcastle and external research grants. And so that's really just an example of what, you know, a Rolls-Royce version looks like, but a really good example nonetheless. And just in terms of perhaps my own reflective practice here on the presentation, I haven't presented this type of presentation before, but on reflection, it did, you know, I'm an evaluation evangelical, and so I'm really kind of keen to see, you know, better use of evidence in practice and better use of evidence to inform decision making. And, you know, the presentation may have come across as, you know, very kind of deficit aligned, but I probably just wanted to finish by, you know, just saying that I've never really seen agencies not gain by better or more investment in research and evaluation, and kind of to the contrary, you know, those that do are often those that prosper. You know, evaluation is a really empowering exercise. It builds your confidence as a team. It gives you, you know, you can see that your service is on track, or you provide you clear direction to, you know, improve the impact of the services. It allows you to see the impact that you're having, which is incredibly motivating for those within your team. And importantly, gives you the due acknowledgement for your great work. You know, with evaluation, you can kind of surface the great work that you're doing and promote that work, you know, up the hierarchy within your own institution, or, you know, outside it to, you know, so that others can kind of pick up, learn from you and kind of take on your policies and programs for the benefit of their community. So I think I just wanted to make sure I finished on a, you know, a note really kind of making the case for the benefits of, you know, research and evaluation and the integration of research, evaluation and health promotion practice for the benefits of you as individuals, as a health service, and for the communities that you serve. Thanks.